So nodal vital signs. All right. By the end of this, I expect you to memorize this. You'll be quizzed on it. Okay. Again, here it's really trends. Okay. If you look at trends and you know, newborns, they breathe really fast, and as we get older, we don't breathe as fast. Heart rates are really fast, and then they're not quite as fast. Blood pressure are really low, and then they go up. So it's more along the lines of trends, and there's some different formulas out there that you can say, 70 plus age is what the ideal, newborn up until, or their age per month. Plus 70 will give you your systolic blood pressure. Don't worry about that. Okay. Really look at trends, knowing that a newborn, he can be breathing up to 60 a minute, and that's normal. Heart rates 130s to 140s, up to 200s, and that's normal. Okay, and then goes down. That's the biggest thing. So when you look at the kid, and when we talk about a little bit with the PAT, it's yes, the kid looks good, but he has a fast heart rate. He's breathing fast. Is that really a bad thing? And again, just talk about the age and the weights and all that stuff. If you don't have a Braslow's, your 1 year old, your 5 and 10. Again, just go back to reiterate your 10, 20, 30 rule. This has really saved my rear end many, many times. I used to love Grey's Anatomy. I've watched it forever. All right. So whenever I lecture or whenever I give, I always start off with a little bit on, anatomy, physiology. We've always forgotten it. Some of you probably haven't dusted off the EMT book in a while. Over and over again. The only way I remember a lot of it is because of the lecturing. So pediatrics, size. Okay, they got big heads, little bodies. Okay, their neck's not well developed. They don't have as much blood. They get their abdomen, their skin, and all that stuff is really close. They're lower to the ground, so they have problems with heat exchange. So there's a lot of factors to take into consideration. Heads, 60%. Okay, the majority of blunt injuries is the head. We know, the little, your toddler that is just starting to walk. What happens to them? They trip. Boom. Okay, they take the face plant over and over again. That head is like the lawn dart. Okay, it's a projectile, and that's really what they go. They have not as thick skulls, so the problem there is the potential, especially with the fontanelles. Fontanelles don't close until the age of 2, so the potential risk of damaging the brain itself more from the impact because the skull's not protecting it. And then from there, smaller faces, which in turn makes it difficult, for our EMTs or our advanced EMTs and paramedics to be able to intubate. Next, they have a greater laxity. Again, smaller neck, big head. Okay, all the spinous or the ligamentous processes and all that stuff are not working, or they're not as strong. So what happens in a car accident? So you got big heads, small necks that with lax. Okay, car accident, crash, boom. What happens? Exactly, they got the bobblehead going. Okay, this is one of the reasons why kids should be rear facing. Okay, what is it? 20 pounds in the age of at least 1 or 22 pounds. It's been a little while. Okay. In the Pediatric Association now is saying as long as the kid can be in a rear-facing car seat, that's the ideal. Until they outgrow it, is really the ideal place because they look at what trying to prevent neck injuries in the kids and all that stuff. Always think about from the aspect here when we talk about airways. If you lay their head down, they have a big occiput, so it's going to push the chin towards their chest. So you might have to put a pad or something or a towel roll even under their shoulder blades, okay, to help them for breathing and all that stuff. Or if you're going to be potentially intubating and all that. The ribs are more horizontal versus the adults. Our adults, they go at an angle. There's wrap around the body. They have small intercostals, or the intercostal muscles aren't working as well. And from there, the breathing side of it, okay, what's the largest muscle in our body, or in the abdominal, for breathing and all that stuff? The diaphragm, okay? They rely on the diaphragm for everything, okay? So how do kids, what are kids predominantly called? Belly breathers, all right? They breathe with their belly because of the diaphragm and all that stuff. It's a bad sign, or it's an ominous sign, when you see more of the chest and less of the belly in the kids and all that stuff. Mediastinum is more mobile, and then from there, thin chest walls. If you listen, a lot of times you can hear upper airway stuff from the nose coming down to the chest, where it might sound like they're wheezing, or might have bronchi and all that stuff, just because of how everything's transmitted through. Cardiovascular, heart rate. Okay, up until 1 to 2. Okay. Actually, going back to the chest and lungs, one answer I forgot, they're what's called obligate nasal breathers. They usually see to about the age of 1, right? Because most of the time, if you think, pre-industrial time period, how did kids eat? What was their source of nutrition for infants? Nursing, okay, the breast. All right. How do you eat and breathe at the same time? Through the nose, exactly. So to about 1, if they have clogged nose and all that stuff, they can't breathe, which means they can't eat. All right. So a lot of times for them, when we talk about a little bit with the bronchiolitis, you get your 6, 7-year-old this time period when it's starting to get cold, RSV, non-RSV, bronchiolitis. They got the runny noses and all that stuff. If even the simplest thing of taking the blue bulb syringes and suctioning their nose out, it saves them, okay? You guys can cure a kid just by suctioning the nose. And then you're a hero. Mom pat you on the back. Yay, you saved my kid. Right. So heart rate, they have a limited reserve. We won't really talk about the, actually, we can. Cardiac output equals what? Told you, that quiz. Heart rate times what? Stroke volume. All right. So stroke volume is the amount of blood that squirts out per beat, and of course heart rate. Okay. The cardiac output is heart rate times stroke volume. Stroke volume is based on 3 things: preload, afterload, contractility. Different story, different topic. All right. Really though, the biggest, they don't have a big heart, so they can't circulate a lot of blood. Of course, they don't have much blood anyways. So they get a very small amount of blood to be able to squirt through the heart. So how do they maintain their cardiac output? Through their heart rate. That's why kids, they can teeter at 180, 200 beats per minute for an hours on end. Okay. And then what happens though to them? They're done. Okay. They crash fast and hard. All right. So be very careful and ominous. Again, you get a kid that's beating at 200 a minute. One, find out how long it's been going on, and then prepare for the worst, because it's going to happen. It's going to happen quick. Bradycardia is not a good thing. It's usually due to lack of oxygen. And then, of course, with the blood pressure, they can hold it a little bit longer than adults. And then from the aspect of the blood volume, larger, it's proportionally larger because they have smaller bodies that we'll talk to in about a second. Their absolute volume is lower. Right. So a newborn, they have about a soda can, 12 ounces. Your 60-pound kid, which is about what age? 10, 11, okay, because 60 pounds, how do we get to kilograms? 2.2 or half, whichever one, okay? And then going back to our 1, 5, 10 rule, okay, so 1-year-old is 10, 5-year-old is, okay, 9, 10-year-old, 30, okay? So 1, 5, 10, and that's about that. And then, of course, once we get to 125-pound adults, all that stuff, they have a couple liters of blood. Small blood volumes, again, talk about the rapid blood control, and then they go, quickly through the sudden irreversible shock. So they're doing well, doing well, doing well, and then they step over the cliff and plummet, and you can't get them back. Blood pressure, again, from the aspect, not always a good thing or be able to control. So what's a good way to measure how well their circulation? And we'll talk about this a little bit with the PAT. Look at them. Specifically, what are you looking for? Pink, warm, and dry. What else can you check for? Skin turgor, cap refills. Okay. Okay. So in a black child, okay, where's another good place to look at? Sclera and gums under the tongue. Have them lift up their tongue. Look into the buccal mucosa and all that stuff. All that stuff, low consciousness, talk about that. Cap refill, just push it down and see how long it lasts. Ideally, it should be no more than less than 2. Okay. Respiratory, the whole aspect with the tidal volume. They have small lungs, small chest, so they can't take in as much. We know this. And then from there, the oxygen demand is higher. Okay. Heart rate is equivalent to metabolic demand. The faster our heart rate is, the faster our metabolic demand is. And that's one of the things that when I talk about different things like STEMIs, why in the guidelines we give medications to make patients not as anxious and not have as fast as a heart rate. Because if I can lower the heart rate down, I know that I don't need as much oxygen. Same thing with kids. If I can slow them down a little bit, don't have them breathe as fast, they're not going to have as much problems with needing the oxygen. Airways, again, big heads. Occiput's big, so it tilts the head forward. Okay. They have big tongues, small airways, small neck, which in turn leads to all the problems inside the airway and all that stuff. They get a floppy epiglottis, which is omega shaped, and then the cricoid cartilage is the narrowest point. In adult, what's the narrowest point? The vocal cords. Yep. So the vocal cords itself. So it's a little bit past the vocal cords, and this is one of the things we talk about ingestions a little bit later. Okay. Your little grape, okay, they suck the grape. Where does it go? It gets past the vocal cord, and then it gets stuck. All right. Right in the cartilage and all that stuff. Absent mouth breathers, again, we talk about the obligate nasal breathers. Neck overextension can sometimes cause problems with the glottis. And then, just opening their jaw, giving the good lift, head tilt, chin lift, grabbing again, if you have to reach in there, grab the mouth and the tongue and lift that up. Put in your oral airways, NPs, your nasopharyngeals, and all that stuff to help out. Big tongue, small airway, the crico cartilage there. That's usually the place for blockages versus the adults. Just different. And then from there, the other aspects, when you start drawing your lines through everything for accesses. I'm going to talk about that right now. Obligate nasal breathers, diaphragm breathers, abdominal breathers, weak accessory muscles, and then, what is deemed an increased respiratory rate. 30 for a 4 or 5-year-old is normal. Okay. Now, a 4 or 5-year-old that's breathing 60, there's an issue. Okay. So respiratory failure, leading cause of death in pediatrics. Okay. They don't die from sudden cardiac arrest. They don't die from STEMIs. Okay. They die from lack of oxygen. Correct. Yep. Anything and everything that causes the lack of oxygen. All right. So in the abdomen, they don't have as much abdominal muscles. They're missing the linea alba. So you can, walking, my little 5-6-month-old, I can go and push on his belly. You can feel anything. I feel the poop. I feel the liver, the spleen. You can almost push back far enough and feel the spine and all that stuff. they get a big liver, big spleen, and all that stuff, which that's, for accident-wise, except for the head. In the abdomen, blunt injuries, that really takes the effect because they have such huge livers and spleens and all that stuff. Not as developed, age of 8, that's how the brain is working. So I think my dad screwed me up a little bit when he was giving me beer at 4. Maybe not. Increased risk of damage from the aspect, I don't know how it is out here, but in Toledo, one of the things that they check by the age of 9 months with lead screening and all that stuff. Some of the lead plants there, all the homes that were lead-based paint, things to take into consideration. So if you walk in there and I'm not talking about, I don't have milestones or in here or anything like that, but things to take into consideration. Okay, when should a kid be able to sit up? 6 months. Okay, when do they start rolling over? 3 to 4 months. Okay, so sitting up, or start rolling at 3 to 4, sitting up by 6. When do they start pulling up? 8, 9 months. Okay, and then walking, a year. Okay, so those are one of those things when you get into your sample history and the questions, and to be asking. Okay, but you got a little toddler, he's 2, but he's not, not walking. Why? Okay, things to be asking questions and all that stuff. Other information. Extremities, they have small bones. The growth plates don't really till about the age 17, 18 is when most of the growth plates are fused. And then the IO axis, getting into the anterior proximal tibia. Did hear a lecture today I'm going to send to Chief, where they actually talked about doing IOs in the distal femur as one of their places, the lateral distal femur for little ones. Yeah, as another potential spot and all that stuff. Correct. Yep. Skeleton, again, they have more connective tissue. The bones are, the connective tissue is stronger than the bones, so they don't strain or sprain. They break more. And of course, depending on what type of fractures, when we talk about the non-accidentals, the rotations, green streak fractures, and all that stuff. Usually a force, if it's a nice clean break, there's a lot of force involved with all that stuff. Skin, thin, elastic. Usually, or from the aspect, they're like the adults. They have the skin as the largest organ of the body. But it's also from the aspect they have small body mass, lots of skin, so they don't have the ability to control their temperatures and all that stuff. So they cool off real fast or they heat up real fast.